All right, and so we're going to be talking about deltoid ligaments, looking at acute repairs as well as chronic reconstructions. What's the difference and when do we fix them? And I think that this is a broad category and term. Usually in the traumatic setting is when I tend to think about that philosophically as when we do a repair, and when we're looking more at a reconstruction of the deltoid structures and deltoid ligament. I see that often in the chronic setting where the tissues are attenuated, can be with or without a flat foot. And so we'll kind of go through those and help understand what really is entailed in the different types of repairs versus reconstruction. I think it's important for us to really understand the anatomy, and that when we say deltoid ligament, we're really talking about a constellation of ligaments that support the medial ankle and hindfoot structures. And this is inclusive of the tibiospring and the spring ligament itself. I think Dr. Bull will highlight on that in his talk a little bit later, but our philosophy on this is that this is, a continuous organization of soft tissue reinforcement for the ankle and hindfoot. The deltoid ligament isn't an isolated ligament itself, but rather several ligaments who serve multiple purposes to help stabilize the medial hindfoot and the medial ankle. When we're looking in the traumatic setting, where I'm typically looking to do the acute repair type techniques, it's important to understand the trauma that's really going on in these cases. I think arthroscopy in several of these cases can be very helpful. The image on the left, this is a patient who had a simple Weber B fibula fracture that did have some medial pain. And when they have medial pain, that's when I will bias toward doing a arthroscopy before I move forward with the ORIF of the fibula and potentially the deltoid ligament repair as well. It's important to clean out a lot of this acute synovitic hemorrhagic synovitis out of the joint and to lavage the ankle joint as well of some of the inflammatory cytokines which are present. Additionally, it's important to have a thorough inspection of the medial gutter. The image on the right side there on the bottom, that is the talus, and that's kind of looking down into the medial gutter there, and you can see the fibrillated ligament there avulsed, and the tibia, the medial malleolus, is on the far left side of the screen, and you can see that the ligament is actually pulled away. And so this you can dynamically stress with direct visualization in the operative room while you're looking at it arthroscopically, and you can take probes and instrumentation to actually determine how extensive that tear is, getting and sweeping underneath the entire medial malleolus in some instances, at which point a repair is necessary. So here's an example of a simple Weber B, really not much going on. The fibula's already been fixed. Clear space looks normal. The medial clear space, the tibial plafond looks normal, and there's congruency through the joint. What we see here with valgus stress, though, is that we're able to expose the deltoid injury, which is present. And so this is not actually just a simple Weber B fracture, but rather a bimalleolar equivalent with deltoid ligament tear. And some of the old theory and thought on this, which largely came out of the traumatology side of orthopedics rather than the foot and ankle reconstructive side, was that the deltoid ligament would heal itself. Once you had fixed the fibula, it couldn't really go anywhere, and you just let those things scar on its own. As you're watching through the literature and anecdotally speaking with surgeons who have a greater emphasis, at least in the United States, on foot and ankle specific surgery rather than global broad orthopedics, the tendency is starting to trend towards much more stringent criteria to go ahead and fix the deltoid ligament in these cases when there is acute trauma to it, rather than to let it scar in on its own. So I tend to have a very low threshold to think about the deltoid ligament, clinically palpate that area before I see the patient, or when I see the patient in the office before we go to surgery, to determine, is there ecchymosis there, is there soft tissue effusion there, is there instability there, is there pain there? And if those things are present, I have a high likelihood that I'm going to also be doing a ligamentous repair of the deltoid at the time I fix the fibula, even if it's a unimalleolar, relatively simple fibula fracture like is shown here. There is still soft tissue injury on the medial side. Dr. Reb alluded a little bit in his questions to to I think this paper as well, looking at some short-term results following ruptured deltoid ligament with acute fracture fixation of the fibula. In about half of these, there are 78 patients, about half were repaired directly and about half were not repaired. What they found is with those who had the deltoid ligament repair, they had an improvement in the medial clear space with that repair. And then more importantly, it correlated to clinical outcome differences also when the syndesmosis was involved. And so that's what Dr. Reb was talking about, where he'll include a superficial deltoid ligament repair in the instances when he's doing the syndesmosis. There's literature-based evidence that shows us that there's an improvement clinically when those structures are correlated. And I think the deltoid ligament is involved a far greater percentage of the time than we appreciate in a lot of these traumatic ankle fractures. And so when we look at this intraoperatively, what we typically see, the image on the right, this is a common mechanism for the deltoid type tear that we see with a lateral based fracture where the medial malleolus is not fractured, and that's a sleeve type tear off of the tibia. It's technically pretty simple to repair these, and it's quite obvious when you get in there. And the thing is, you'll have a little bit of a retinacular layer that actually overlies the ligament. And so you can't just look at that and say, okay, I can't see the tibia right away. I see tissue, so the deltoid ligament is fine. As soon as you incise through that little bit of retinacular layer, you'll fall right into the hole that is the medial malleolus, and you'll find the wispy fibers of the deltoid ligament, the mop ends essentially. I tend to use two small all suture anchors to repair this. I try to have them oriented off axis of each other, which is demonstrated in the central picture. One oriented more toward the navicula, thinking about the tibiospring or the tibionavicular branch of the superficial deltoid, and then one oriented more from the medial malleolus down toward the sustentaculum, which would more represent the tissues of the deep deltoid ligament. So I try to do both of those. And then you can see the repaired product on the right side. And here again is another example. You can see the contused tissue on the image on the right. That's after I've completed the tear and I'm looking to move forward with the repair. You can see the contused tissue on the medial malleolus there as well. Two anchors again placed at roughly a 45-degree angle for me. And then the image on the right is showing sewing that large cuff of tissue that you're able to create to reinforce. The other thing in these cases that I think is important is the image on the left shows the sutures are now on the foot side after the ligament is repaired. I actually take those back up and pass the needles one more time, which is shown on the image on the right, up onto the tibial periosteum. And then sew another. I'm able to advance that tissue a little bit more strongly, a little bit better, and get a little bit more robust repair, and also take some strain off those distal knots as well by passing back up onto the tibial periosteum. So I won't just do the image on the left and stop. I'll include the separate step for the image on the right as well, just as a technical tip and pearl. So then moving on to the chronic deltoid reconstruction, this is when we're seeing that the tissue is largely degenerated. It's not healthy collagen anymore at this point, and the ligament itself is attenuated and non-functional. Typically, we're seeing this in conjunction with bony deformity. It's common in advanced stages of posterior tibial tendon dysfunction. Most commonly, you associate this with stage 4 when you have ankle valgus, but there's some, if you look at this radiographically, what's considered stage 3 versus stage 4, and I'll highlight some of this in a case example at the end. Some stage 3s actually do have deltoid insufficiency. It's just there's a bony block preventing it from actually being radiographically appreciated. So those are the ones I think you really have to be careful of and make sure that you're appreciating with your intraoperative assessment and you're prepared to fix it if you find it in the surgery. It can be isolated without a flat foot or can occur with a flat foot. I think this is where some of the interesting conversations can come. You can have ankle valgus associated with ankle arthritis that has nothing to do with the foot itself. You can have a flat foot that is either stage 3 or stage 4 that would affect this. And then Dr. Burlett talks a lot about as well, and he may, in some of his discussion, as well as potentially some of the cases later, what's called global ankle instability, where the lateral ankle ligaments as well as the deltoid are all involved, and that can be independent on anything that's going on with the foot. So deltoid reconstruction doesn't necessarily always need to occur in conjunction when thinking about flat foot. The foot type doesn't necessarily matter. Where do we commonly see this? We advocate hindfoot fusions and do a lot of what we call medial double arthrodesis with subtalar joint and talonavicular joint. This obviously is a case preoperatively where there was an ankle valgus. The deltoid ligament wasn't fully appreciated as an important pathologic portion of what was going on for this patient. And there you can see a couple of years after the surgery, there's actually been an induced ankle valgus deformity now, which is leading to arthritis for the patient. So these are obviously the situations that we want to avoid. This is a study Dr. Burlett, Dr. Heyer, who's also with our group, and some of our colleagues had done several years ago now, looking at the difference between triple arthrodesis and medial or double arthrodesis. And what they found is that ankle valgus was more common in the triple arthrodesis group rather than the medial double arthrodesis group. And if this is anecdotal on my part, but I think part of the reason potentially for this is that with the dissection, when you're doing a medial double, you're paying more attention to the deltoid ligament because of where your dissection is, and so that's forcing you to actually repair those tissues on the way out. So you'll more appropriately identify any instability is there, and you're able to address it because you need to maintain those structures based on where your dissection is. So it's just an awareness as much as anything else. Several different types of repairs that can be done. Commonly in certain parts of the country and world, these zero stretch braided type repairs are done. If you look at the image, though, you can see there's a portion of the deltoid ligament and a very important portion of the deltoid ligament that isn't exactly assessed in this. And so these vertical type repairs with one arm into the talus and one arm into the calcaneus completely negate to include the tibial spring or the tibionavicular portion of the ligament. This is an allograft type reconstruction using similar technique to what you can do with the suture tape. And so really there's a lot of different material that can be used for this. More commonly, this is what my current application and technique for a deltoid ligament reconstruction is. This is a flexible, elastic, stretch, synthetic ligament that can be used that we have access to in the United States. I use a blind tunnel with two arms coming out of the medial malleolus, which is on the upper left-hand side. And this is anchored into the medial malleolus using an interference screw. And then directly below that, there's a deep arm of that, which is it's about half of the length. So the arms, one arm is about a third of the length of the overall tape or device, and the other arm is about 2/3 of the length. The relatively shorter arm functions as the deep deltoid, and I use a modified closed tunnel technique where I can tension that by anchoring that with another interference screw into the sustentaculum tali. You can see there, this is a flat foot case. I've also incorporated an FDL transfer. And when I'm doing those things in conjunction, for me, I use the FDL transfer from the bottom where that passes up through a tunnel in the navicular. And I will take the superficial or tibionavicular portion of the ligament and I will pass that from the top down and tension those two structures against each other. So I'll do my ligamentous repair, oppose the tension with my FDL transfer, and then use a single interference screw within an open tunnel in the navicular to anchor those in place. And then centrally, you can see then I've taken what passes through the bottom of the navicular in terms of the synthetic tape that I use and anchor that back up to the tibia, again, reinforcing further this kind of broad band of tissue that is the number of ligaments that include the deltoid. So having multiple arms, and rather than coming down to the talus, I do think, and Dr. Bowl will discuss this in more detail as well with his spring ligament talk, that it is very important that the tibiospring or tibionavicular portion of the ligament is included in these chronic reconstructions. Again, just looking at the anatomy as a reminder of the different structures we're trying to recreate, including both the deep and superficial components of the deltoid, and highlighting that it is important to extend out to the navicular rather than just negate that and only focus on the talus and calcaneus. Here's an example based off of what it would look like radiographically where we're including that. And again, here on the bottom, you can include a spring ligament reconstruction in that area as well, incorporating the same tissues. And this again was done with medial double arthrodesis. The other thing that's important to note is we have to protect the deltoid ligament after it's repaired as well. And that's how we're going to be able to maintain long-term viability of our repair so that it doesn't loosen and attenuate over time. And the importance in these cases of appropriately stabilizing the medial column is paramount. And that can be done in a number of different ways. The image on the left shows it as a first tarsometatarsal joint arthrodesis to help stabilize the column, whereas on the right, we can use periarticular techniques with cotton tarsal osteotomy. This is a case example highlighting some of these principles of what a stage 3 flat foot basically is. You look at the image on the right and you can see that there is no ankle valgus. There's severe deformity of the foot, but no ankle valgus. The problem with this is that there is such severe subfibular impingement from the extent that the calcaneus is subluxed at the subtalar joint that the medial ankle is not able to even be stressed preoperatively in this patient. And so really the deformities need to be reduced, and it's an intraoperative assessment where then you're prepared to repair the deltoid ligament or actually reconstruct it with the technique just showed if you do that, because you're not going to necessarily be able to determine before surgery how severely that deltoid ligament is damaged. And this is, so technically is a stage 3 PTTD with an insufficient deltoid ligament. And you can see how severe the subluxation of the calcaneus at the subtalar joint is. After surgery, this is what it looks like. Again, not much to see here in terms of the reconstruction itself, but the main thing is to highlight the point of it. And this patient actually had the same on both sides. And it's after you do your subtalar fusion and you do your osseous work with the talonavicular and subtalar fusion, then go back and stress the medial ankle and look for any gapping, widening, or even sometimes you can assess the tissues just looking at them if they are going to be weak and need to be repaired. So in conclusion, acute repairs and chronic reconstructions are very different. I do think acute repairs can quickly and easily be taken care of with a couple small suture anchors. Chronic reconstructions, I do not think suture anchors alone are sufficient to use that tissue and to reconstruct that tissue with. In bimalleolar equivalent ankle fractures, I do feel it's appropriate to fix the deltoid, especially when the syndesmosis is also involved. We should be opening the medial ankle as well. Chronic reconstructions, this is where I think the tissue is just too fatigued and damaged. You need to use tissue augmentations, whether that's a synthetic zero stretch or stretchable implant, or if it's an autograft or allograft, that's up to the surgeon ultimately. And then it is really important that we appropriately protect that soft tissue reconstruction as well by using the appropriate osseous procedures to back that up. Thank you.